to Megan and Debbie and all the others at the PSP Association who've put today's research information session together. It's great to see that so many people have signed up, and I understand that lots of folk will be joining at various points through the morning as well. And I'm sure we're in for a really interesting and informative few hours. As Rebecca said, my name is Karen Morrison, and I've recently taken over as chair of the research committee of the PSP Association. And it's great to be able to chair this first session and also to meet many of you online today. As you're already aware, the PSPA is the only UK charity specifically focused on people living with PSP and corticobasal degeneration, CBD, campaigning to improve the diagnosis of these rare diseases, working towards providing better care, and crucially, funding groundbreaking research into the care, and eventually we anticipate effective treatments for these disorders. The research committee is responsible for the charity's research strategy, in delivering that strategy and then directing the charity's research spend. So I took over from Prof. Nigel Lee as chair of the research committee only a few weeks ago, and I'll be chairing the first research committee of my stint next week. My background is as a clinical neurologist, and for over 30 years, I've combined the care of patients with various neurodegenerative disorders with molecular and genetic research, clinical work as well, with my main focus being on motor neuron disease, ALS. And for the last decade, I've also been increasingly involved in university healthcare education leadership. And actually, I'm currently the Dean of Education for Medicine, Health and Life Sciences at Queen's University Belfast, from where I'm speaking to you today. And I can tell you that the sun is bright and shining up in the northwest of this little corner of the UK today. We're going to hear today about ongoing research looking to improve the quality of care and symptomatic treatments for people living with PSP and CBD, as these are still diseases for which there is no curative therapy or treatments that significantly alter the disease course. But by way of lifting your horizons and encouraging us all to look positively to the future, in the next 2 minutes, I'm just going to tell you about my earliest research in neurological disease over 30 years ago, when, as a young doctor, I embarked on my PhD project in Oxford, aiming to identify the mutated gene responsible for the commonest cause of motor nerve disease that affects infants and children, a disease known as spinal muscular atrophy or Verdnig-Hoffmann disease. My research then, back in the 1990s, helped to narrow the region of chromosome number 5 that contains the causative gene for spinal muscular atrophy, SMA. And we were just pipped to the post by a team in Paris who eventually identified the gene in which there are mutations, the survival motor neuron gene, SMN, back in 1994. Genes encode proteins. Proteins affect cellular function. And back then, our focus was on identifying the faulty function then of the abnormal SMN protein and looking for ways to bypass the function of that faulty protein. Not in my wildest dreams then did I imagine that just over a decade later, there would be actual genetic therapies, gene therapies that would modify the function of the abnormal gene so that nearly normal protein would be made in the patient's own nerve cells and nerve cell function would be restored. And that's indeed what has happened in childhood onset SMA. Gene therapy for that form of SMA is now available to babies and children with the chromosome 5 gene mutations delivered here in the UK in NHS hospitals. And that gene therapy seems to be curative. So the oldest children who were treated in infancy are now active, normal teenagers, running and jumping and singing and dancing or doing whatever normal teenagers do, which is probably be on their phone most of the day. But those children are more than 10 years having had that first gene therapy delivered into their spinal cords. So research can and really does deliver the transformation of care to cure. So while there's no cure yet for PSP and CBD, I hope that you can take some hope yourselves from me telling you about the novel successful treatment in another previously considered untreatable nerve disease, that is childhood onset SMA. So research in PSP and CBD is indeed ongoing to find the causes of and then working towards identifying truly effective treatments. Please keep your eyes on that horizon, that is what we're working towards. And so on to today's session, which is focused on updating us all on research aimed to improve the quality of life and treatment of symptoms in people living with PSP and CBD. And I'm really pleased now to introduce our first speaker for the sessions, Dr Boyd Ghosh, who's a consultant neurologist working in the Wessex Neurology Centre in Southampton and in Salisbury Hospital. Boyd has undertaken research over many years in aspects of CBD, PSP, and also multiple systems atrophy, beginning with his PhD studies back in Cambridge. Boyd is a trustee of the PSP Association, and he's also on the research committee. And as if we're not all linked together, I worked alongside Boyd as a consultant neurologist when I was Associate Dean at the University of Southampton from 2016 to 19. So Boyd, I'm very much looking forward to your presentation to us today entitled, How to Provide the Best Care for People with PSP and CBD. Welcome and many thanks for speaking to us now.
Thank you very much, Professor Morrison, and welcome everybody. Hopefully you can all hear me. Maybe Professor Morrison could just nod if she can hear me. Excellent, lovely. So I'm going to give a short talk about, to some extent, the difficulties that people face with PSP and CBD, and what we as a regional clinic and what we as a research centre are doing for that. I should start with my disclosures. So as Professor Morrison said, I'm a trustee and a research committee member for the PSPA, and I've lectured for drug companies and been on their advisory boards and helped with drug trials largely around patients with PSP. So, as I said, I'll discuss some of the difficulties that people with PSP and CBD have, and this is probably one of those meetings where I don't really need to go into much detail because the majority of people on this call are people with lived experience of it in one way or another. And then I'm going to discuss the treatment guidance that does exist and why this is not always provided, and discuss what we're doing to try and improve that care. So PSP and CBD are rare diseases. So basically 4 to 6 people in every 100,000 might have the disease. And that means that a GP doesn't see it very often and may not know much about it. And many people in the hospitals that people go to may not know about it either. It's rapidly progressive, and people have difficulties with moving, eating, speaking, and other aspects, which I probably don't need to go into for this audience. So there's been some research in PSP about the quality of life that people have, and there's possibly not as much research as I would like, but the research that we have had shows that the quality of life is poor. So this is a graph here of all the people. Now, maybe Professor Morrison, can you see my marker?
Absolutely,
yes,
fine, all fine.
So this is a graph with good quality of life on the right and bad on the left. And you can see the general population here on the right, fairly good quality of life. People with motor neuron disease, which Professor Morrison mentioned briefly, have quality of life around here, but PSP has a quality of life which is the lowest of all of these conditions that are considered, and that includes Charcot-Marie-Tooth disease, multiple system atrophy, motor neuron disease, Huntington's disease, ataxia, depression, stroke, diabetes. That's perhaps not a surprise to people, We also looked at the quality of life for carers in some research that we carried out a few years ago. And just to give you some idea, we found that 80% of patients are cared for by their spouse, and 70% of those look after their spouse 80 to 100% of their time. And when you compare the difficulties that carers face, the kind of burden they have, and and their depression as a result of their caring duties, then that's worse than even those people who are looking after people with Parkinson's disease, and a similar carer burden, if we can use that term, to people who look after their family with Alzheimer's disease. And the median score, if 104 is bad, if a high number is bad and a low number is good, the median score on a carer quality of life scale was 55. What we found when we looked at this in our cohort patients is that carer quality of life worsens as the disease worsens and is correlated to the patient quality of life. So if we can improve the quality of life for the person with the disease, then perhaps some aspects of the carer's quality of life might improve as well. Separately from quality of life, we also want to think about, well, if we're trying to establish a reason for the NHS to do something about this, well, is there an economic cost to the NHS for people with PSP? And there is. So in 2011, there was a drug study. And as part of that drug study, there was a separate study which looked at the cost to society for looking after people with PSP and for their care. And actually, we can see that the care for someone with PSP was higher than for people with MSA or Alzheimer's disease or multiple sclerosis or schizophrenia. And so the costs in the UK, the total cost in the UK for patients with PSP in 2011 was £195 million, which is a substantial amount of money. And the authors of that study estimated that 40% of the costs were inpatient costs. And so the PSP annual inpatient costs were 78 million in 2011. But figures are difficult to get. And there's a number of reasons for that. So until 2018, so we would want to get figures for the cost for the NHS as a whole and use the NHS's own data for that. But that's difficult because until around 2018, progressive supranuclear palsy, due to a way that it was coded, was actually coded as motor neuron disease. So when people are admitted to hospital, their diagnoses are put on a discharge summary, which is sent to the general practitioner, and a team of people will code all the information on that discharge summary and in their notes, and will provide that information to the NHS. Because of the way that progressive supranuclear palsy was coded at the time from an international classification of diseases, it was coded erroneously in the vast majority of cases as motor neuron disease, including for death certificates. Since 2018, that's changed, but at the moment, there is no coding for corticobasal degeneration, which is clearly for that disease alone. It's lumped in with other diseases. So figures are difficult to get. In Israel, PSP costs, there's been a study more recently, that was in 2023, and PSP costs have also been shown to be excessive. And if you look at these graphs, the top graph here is a graph of people with PSP a year prior to their diagnosis compared to their a general population member, so someone without any diseases. And the bottom graph is a graph of people a year after their diagnosis. Again, people with PSP on the left and people just from the general population on the right. You can see that the costs are higher for people with PSP than for the general population. And interestingly, this light green bar is hospital costs and outpatient visits. And you can see that these are higher, much higher than those for people in the general population. And a year after their diagnosis, it's much higher again. So that's important to say that actually there is a reason why the NHS might be interested in this. So how should we be treating patients? Well, there are no statutory guidelines. So there's nothing on the there's nothing that the NHS or the government require hospital trusts to do for people with PSP and CBD. So there's nothing mandated that you're required to do by law or by constitution. However, there are lots of best practice guidelines. So there's the National Neurosciences Advisory Group, there's the Right Care Toolkit, there's the PSP Association's own professional guides and their care pathways that they've done. There are prominent papers from people who are experienced in PSP and CBD and their suggestions of what should be happening. One of which is James Rowe, who's a professor in Cambridge, who I studied with for my PhD and work closely with still. But there's also people from across the Atlantic, from the US, where they also say what should happen. But these don't often happen. But what do they say? They say largely that we should be treating patients with specialist services, so they should have a specialist service for diagnosis and treatment. So if people are not sure because it's a rare disease, they should be able to refer them to a specialist centre who have experience of diagnosing them early and for their treatment, their medical support. There should be a multidisciplinary team consisting of therapists and other people that can offer them support on an ongoing basis to provide them with help for mobilization or for speech and language or for swallowing. There should be a care coordinator, so someone that people can access in between times to enable them to provide advice rather than them attending hospital at short notice. Patients should be offered a feeding tube if their swallow is deficient. It's up to them whether they take it or not, and that's certainly what our clinic would do, but we would have a conversation with them early. And we should have timely access to specialist equipment, such as a wheelchair, and for motor neuron disease, for example, the waiting time is perhaps 1 or 2 months. For PSP, it can be a year or more, as I'm sure I don't need to tell any of you. And there are other suggestions that people have about what should be offered to people with PSP and CBD. But there are large areas of the country where this doesn't happen. And for many of these suggestions, it doesn't happen at all. And why is that? So the NHS is struggling with demand. There are long waiting lists for outpatient appointments, and the NHS is struggling with money. And I'm sure you've had some information from the news about the NHS and various aspects of the difficulties that it have. I don't think it's a surprise to know that there is a big bill for the NHS, which hospitals and their integrated care boards, who are the people that provide them with the money, are struggling to meet. And so there is a lack of money, and so therefore all NHS trusts are having to reduce their capacity in order to meet that expectation of trying to stay within their budget. So faced with the above, the NHS has to prioritise. If there is strong evidence for something, then they will support it. So for example, at the bottom, I can say there are examples of evidence that NHS supports. So in MND, for example, the survival time to 5 years for people with motor neuron disease is greater in those seeing an MDT than those seeing a neurologist alone. And there is useful information about that. And that's the kind of thing that people would, that's the kind of thing that the NHS will say, well, we have to do that. And that forms part of the NICE guidelines. However, there is little evidence that best care for patients actually helps in patients with PSP and CBD. There's lots of support and opinions, but no real evidence that the NHS would say to trusts, you must do this because we know that it really helps. So that's a rough idea of the issues that I think people with PSP face and the NHS faces. So we have a regional atypical Parkinsonian syndrome clinic where we see people with PSP and CBD in Southampton, and we serve Wiltshire, Dorset, and Hampshire, which is a population of around 2.5 million. We have 2 consultant neurologists. We have 6 clinics for people a month, roughly. We see around 100 people with PSP and 26 with CBD. And we have a clinic coordinator, and we are multidisciplinary. That's not sitting in clinic, that's purposefully in the community, so that people, the community teams, which are much more extensive than we could put in clinic, have buy-in to see people. And we, by having this MDT in the community, which we have much contact with, we are aiming to build up their experience and build up their confidence of seeing people with PSP and CBD. And we were lucky enough to get a network grant from the PSP Association, largely as a pilot, to provide support and training to those people in the community who are seeing people with PSP and CBD to try and increase their expertise and their confidence, and see if we can use that as a model for other areas of the country. We have strong links with palliative care, and we have some local joint clinics, particularly in the regions where we see people more locally to their home. And we have clinical trials assistants and research registrars to try and improve research. And this is a research forum. So what research are we doing? So the PSP Association gave us a grant in 2022 to look at the differences in patient care in our clinic. So we have a large clinic. There are some areas of our catchment where people have not very much input from a community multidisciplinary team. They might, for example, see a physio for a couple of weeks and then not for a year or two. They might have speech language therapy, but not in person because they live so far away. Other places see people very frequently. They might see a physio or an occupational therapist or a Parkinson's nurse or practitioner every 6 weeks or so. They might see a speech language therapist on a regular basis every 6 months. They might come into our clinic every 3 months because they're much closer. They might have contact with our care coordinator. So this small grant was to look and see if there were differences for those people that are under different levels of care. Now, it was a small grant, and due to cost pressures, this was carried out by medical students, which were only with us for 3 months of the year, and so recruitment was slow. But the PSP Association, and this was called UHS Collapse, the PSP Association gave us a grant based on some of the data that we got from this early study to do a much bigger study where we compare patients who are seen in our centre to people who are seen in other centres where perhaps they only see a general neurologist and they might only see them once a year, or they may be even discharged and not seen by a neurologist at all. And we've recruited a part-time doctor to recruit those people, and we have a few bureaucratic hurdles to go through, but we're hoping to open formally in the next few weeks. But if anybody is interested and feel that they don't have access to a specialist centre, which is what we're particularly interested in, and they live within a few hours drive of Southampton, then we'd be interested in hearing about you, because we'd be interested in trying to include people in the study with that kind of background. And I also mentioned that we have a network grant to try and look at how we might improve the expertise and confidence of people in our region more with looking after people with PSP and CBD. So outcomes from research. So we're currently analysing data for our clinic patients to see what differences in care leads to differences in outcomes. As I mentioned before, we have baseline data for 80 people, and someone is working on that now together with some statistical support, and we're hoping to provide some kind of outcomes for that in December 2024. We're about to submit a paper, and we're presenting an abstract in the US at a conference looking at the deterioration in function for 3 people when they're admitted compared to those who weren't. So some people who have PSP and CBD, when they're admitted, they do a lot worse when they're admitted than if they were able to stay at home. We want to quantify that, describe that, and then perhaps provide some guidelines to see how we could mitigate that. And we're working with a physio professor and an occupational therapy lecturer, as well as part of our team, to see if we can provide some guidance to people. We're presenting an abstract to this movement disorders conference in the US, showing that apathy exacerbates carer difficulties. This is a busy slide, and I'm not expecting you to look at it in detail at all, but just to show you the poster that we're going to be presenting at this movement disorders conference in Philadelphia in a couple of weeks' time. And basically what we did was we took people, admittedly at this point, a small number of people with atypical Parkinsonian syndromes of PSP, CBD, and MSA, and we looked at their impulsivity and apathy with James Rowe, who has done some work on this. And we saw that apathy correlated, so that means that as apathy increases in someone, then their impulsivity seems to increase, but more importantly, that as apathy increases, their carer burden score, so the amount of difficulties that their carer have, also increase. So I'll do it on this screen, which might show the marker. So as you increase your apathy here, your carer burden score also increases. So that is important, because actually what that means is that we might be able to think about what we could do to mitigate apathy, or to mention that to the carers and see if we can try and reduce the burden or the difficulties that carers have. So other outcomes, importantly, due to the first smaller study that we were able to fund through the PSP Association, we were able to make a case for the bigger study to look at different centres. We have 80 participants recruited with access to their clinical data, and interestingly, as part of that, we can try and answer some other questions about care. So, for example, the use of feeding tubes in people with PSP and CBD, should we be doing it? What are the benefits? We're hoping to report on that in December 2024. Can we predict fracture risk in people with PSP and CBD? We're hoping to report on that in March 2025. How do NHS trusts and hospitals code PSP and CBD? And can we use that to determine admissions? So we're hoping to report on that, hopefully next year around this time. Is there a difference between outcomes for specialists and non-specialist centres? As I mentioned quite extensively before, and we're hoping to have some preliminary data in August 2025, and the study finishes properly in around August 2026, and we're hoping to have a paper published for that as well. And what are the differences in care between different diseases? So if we look at different diseases like motor neuron disease, for example, how does the care differ for people with motor neuron disease and people with PSP and CBD? So I'm coming to a close shortly, but in the future, we would like to have more interventional studies looking at different aspects of care. So for example, physiotherapy, and we'd like to have more unbiased definitive studies outlining the best care for people with PSP and CBD, because if we do, then we can use that as evidence for guidelines and NHS care, and ask the NHS to mandate trusts to provide better care for people with PSP and CBD. And perhaps more importantly for us and for you, we would like to have better care for people with the disease and their families. So none of this work gets done by me alone. There are a big team of people that work behind this. So importantly, the APS clinical team, so Luke Massey, who's the other consultant, and Jay Donnelly, who's our clinic coordinator, but our admin support and nursing support. We have lots of medical student researchers who have done some of the research that I've talked about today, and registrar researchers who helped us, who are middle grade doctors, and collaborators for whom I've received support along the way to provide me help carrying out this research. So I'd be happy to answer any questions, and I'll stop sharing.
Thank you very much indeed, Boyd. That was great, and a great overview of the situation at the moment. And particularly, I'm so struck by the lack of good data and evidence, so that we can help inform commissioners about what services people living with these disorders really need. Before I come on to the questions, and there are several in the chat, and I'll come to those, can you just say a little bit, Boyd, about when you say quality of life, what the measures that are generally used for PSP CBD, do you think they really capture the key elements for people living with these diseases?
So that's a good question. The NHS tends to use a very short measure called the EQ5D. So it asks you about movement and socializing and everything. It's 5 questions. And that is used across lots of different diseases, and is used by regulatory authorities to decide about treatments. However, Professor Schrag, a few years ago now, probably around 2010 or 11, developed a number of different quality of life measures, which were developed purely for PSP and CBD. So the PSP quality of life for patients with people with PSP and CBD, and the carer quality of life for people who look after people with PSP and CBD. And that was done in conjunction with people with those diseases. So those are very finely tuned to these diseases.
And do people in your clinic complete those questionnaires, or can people who are listening to this, can they download that questionnaire and grade themselves against these? Or?
So just to give people an idea of what the NHS is like, in a general neurology clinic appointment, people get 30 minutes if they have never seen the doctor before, and 15 minutes to see the doctor if they've seen them previously. So that's a short amount of time, and doing a quality of life scale is probably not that helpful. You're using those 15 minutes to really try and nail down the kind of current problems that people have. In our regional clinic, we have an hour for people that we've never seen before and half an hour for people who we're following up. If I had half an hour too much, and anyone who comes to my clinic will know that it tends to run over. The quality of life it doesn't necessarily, again, help us to deal with the intense pressures and problems that people have at that point. However, people in our studies would do the quality of life scale, because what we're trying to do is we're trying to correlate things. So I think the quality of life scales are probably more useful where you're using it to guide the kind of treatment. If anybody wants to be part of our studies, like I mentioned, and feel that they're not getting specialist support, then we'd be very happy to try and put them into our study and compare their care and their quality of life with people who do have specialist support.
Sure. Thank you very much. So on to a question. There's a question from Kelly. Is there any consideration of the role of social care in supporting the NHS in preventing inpatient visits? For example, preventing falls or avoiding hospital visits?
So social care is in care, I presume carers are provided by social services to provide care for people. So one of the things that we're doing in our study is looking at the kind of care that people have. So and looking at, in some ways, at that cost, and clearly trying to cost the difference between people who are admitted to hospital and may deteriorate quite rapidly, and people who aren't admitted to hospital and have social care at home. So we are considering that. In terms of reducing admissions, what we would like to see is that those carers are given the support, whether they're social carers or family members, are given the support to help the person with the disease to do as much as they can, but safely, so that they don't fall over and fracture a hip, for example, so that they have the advice they need, so they don't have to go into the emergency department because they're not sure what's going on with their family member. So we are considering those aspects of it, and including kind of nursing home, residential home placements.
Thank you. And Stephanie and Howard have asked the question, what are the reasons for hospital admission? And I guess that's in relation to your study of your 3 people who went into hospital, comparing their course then in hospital with someone who didn't. But generally, why do people with these disorders get admitted?
So generally, there's a number of different reasons. The biggest one might be injuries from falls. So fractures or cuts. Aspiration pneumonia, so often the swallowing is poor, and things can go down the wrong way and go towards the lungs, and that can cause a pneumonia or a chest infection which needs to be treated, and so some people are admitted. Sometimes there is more confusion or agitation, and there's a change, and that could be, for example, from a urinary tract infection or some other infection. So there's a number of different reasons why people might be admitted, and those are probably the biggest 3.
Thank you. Thank you. And Phil McCarthy, he is asking the question. The question seems to start with the GP, a total lack of knowledge about PSP and willingness to understand the effect on the patient. How can we improve this? And it would be good if you could just mention again here about the red flags.
Yes, absolutely. Well done. So the PSP Association has done a lot of work on trying to get the message out about PSP and CBD to GPs and other health professionals. Obviously, in our network, in our region, we see a lot of people, and because of that, we're constantly writing letters to GP surgeries saying, this person has PSP and CBD, and this is why we think that that's the case. So the GPs usually read those letters to some extent, and so we'll be learning. I can see you shaking your head. We had that's one of the things that we can do. We also have a red flag. So the PSP Association published red flags, for PSP and CBD. And certainly a few years ago, I personally sent out the red flag leaflet to all the GPs that I wrote clinic letters to for a month or so. So there was a broad stream of people who were aware of that. That varies from place to place in the country, depending on if you have a clinic. So if there's a big regional clinic in Southampton, then the GPs around me will know a bit more about that. And in fact, unfortunately, there was a person who was referred to my clinic by a GP with possible progressive supranuclear palsy, whose daughter was a GP and who had managed one of my patients with PSP and had recognized it in her own mother. And so because she'd had that experience with dealing with another patient that I'd been dealing with her with. So I think it varies around the country based on the amount of people that are seen there and the regional clinics and the expertise.
Sure.
But we're trying to improve that. And actually, if some of the research shows that specialist clinics are useful and we should put more specialist clinics in, and we can provide a reason for more specialist clinics to be instituted around the country, then maybe that will slowly improve.
Thank you. There are quite a few questions, Boyd, so I'm going to suggest shorter, punchier answers, because
Sure.
there are three on the list here. Is there any active research into best practice in speech therapy?
No. Is that short and punchier? I think there are a few things that we were trying to do, but not to my knowledge that's ongoing at the moment.
Okay. Actually, the next one then, thank you, is more a comment rather than a question about your talk being focused on NHS care, and saying again, what about social services and nursing homes, especially in the later stages when caring at home is challenging? And then goes on to say, my mum had barely any NHS input. We were focused on battling for social care provision, but with no dolls in place and still waiting for CHC assessment when she died. Her final year between hospital, nursing home, hospice was fairly horrific. And I don't know how fairly horrific is reflected in the quality of life scale, but it is, they are heartfelt words there.
We are looking at what we can provide in the NHS. I recognise, so we don't discharge anybody from our clinic. So we would do virtual clinics. We would contact the family member who's next of kin by phone or by video and offer support. Our care coordinator sits on CHC panels to try and see if they can provide more evidence to get the CHC through. CHC is a problem, and the PSP Association are aware of that. And in fact, there is guidance for health professionals who are trying to help people to get CHC. I recognise the situation, and my heart goes out to you. It's a common situation, unfortunately.
Thank you. And just one final question, and it's about symptomatic management, or indeed symptoms, from Scott. Does PSP affect your body temperature thermostat?
I'm not aware of any particular research on that, but anecdotally, so from what people tell me, then I think that there is that feature that can be found. But I'm not aware of research that's quantified that.
Thank you so much, Boyd, Dr. Ghosh. That was great. Great way to kick off the session. Thank you to everyone for putting your questions in the chat. Those of you who are not familiar to the system, I hope you now see how it works. So please don't hesitate to put questions up throughout the day for other speakers. And so we're on to our second speaker now, and this